My name is Myra Martinez. I am your moderator for today. I am with United Porphyrias Association. I am a patient advocate, and I have the pleasure to have actually done this a couple of times now with Dr. Mohamed Kazamel. Dr. Kazamel is at the Mayo Clinic, and his specialty is pain and specifically nerves. Not only that, I also have had the opportunity to come and visit him as a patient. And I asked him before we got started if it was okay for me to bring this up specifically because I know that it's one of those unique situations where not only do I get to work with him from an association standpoint, but also he is my treating doctor as well. In early January, my husband and I made the trip to come out and see Dr. Kazamel as my treating physician. Specifically, I was dealing with a lot of nerve pain at that time. I was dealing with a lot of just ups and downs within my body that I couldn't understand. And Dr. Cozumel took the time to get to know my body, understand my body. And in a nutshell, I just want to give a shout out to Dr. Cozumel because since the end of January, when my medicine started really acting, I have been night and day, completely a different individual. I've been able to do significantly more. I have been in less pain than ever. I didn't realize that it was possible to live without pain. And thanks to you, Dr. Cozumel, I have been living without pain for about a month or so now. So thank you, because without you, that would not have been
Thank you.
possible. And I mention all of this because that's exactly what our mission is as United Porphyrias Association. Our mission is to be able to see a world of patients with porphyria living completely pain-free. So with that, I want to turn it over to Dr. Cozumel to say hello, say a quick introduction, and then we're going to jump straight into the questions. Dr. Cozumel?
Well, thanks, Myra, for having me, and thanks for the kind introduction. You have been a great patient first before anything else.
Thank you.
So my name is Mohamed Kazamel. I'm an senior associate consultant at the Mayo Clinic in Scottsdale, Arizona, and I've been deeply involved with the United Porphyria Association since its beginning and with the Porphyria Consortium on the research side. I'm a neurologist by training, but most of the physicians that I work with in the field of porphyria are typically hepatologists and hematologists. So I am grateful for the opportunity for them to include me and and to collaborate with them too.
Wonderful. Dr. Cosmel, do you just want to really quickly, just from a testimonial standpoint, just give a little bit from my situation as a quick reminder, just very typical AIP. I was fully paralyzed for about a year, had to relearn how to talk, walk, do everything completely all over again in life. And there were quite a number of damages in my body that we found. I don't know what you would like to share in regards to that, but if you just want to give just a quick synopsis of, as a patient, what that was like.
So quickly and briefly, the case has been the result of multiple attacks happening over time. And whenever this is the case, you continue to have what we call neuropathic pain in between the attacks. And typically, what we have been preaching before for the last few years is that there are medications that help more with neuropathic pain than narcotics. I mean, narcotics have a very, very big role during the attack, but in between the attack, we can many times leverage the use of these medications to decrease the dose of narcotics if the patient is on narcotics in between the attacks. I know that sometimes narcotics in many scenarios are indispensable, but we always need to realize that it is not just that we are fearful of or worried about the side effects of the narcotics. Also, the other medications, the medications for neuropathic pain, are the specific medications for that kind of pain that patients with porphyria many times continue to suffer off in between the attacks. So it is not only safer, it is also more specific for this type of pain.
And very targeted, and it works, by the way,
Yes.
for sure.
Thank you.
Wonderful. Well, thank you very much. Okay, let's jump right in. We have a few themes that we have found. So I'll jump into the themes because they seem to be more of the bulk of the questions that we found in advance. The first question, is there anything that can be done to prevent neuropathy or limit the damage to nerves during an attack?
So that's a great question. So if we understand that the neuropathy is because of the toxin accumulation and the effect of the ALA in acute hepatic porphyrias, it becomes easier on us to realize that with every attack, the pain in between the attacks and the degree of neuropathy will get worse. And typically is how to mitigate an attack and how to work around it. You typically know, like, you don't have to experience an attack to know how an attack feels like, but you have to be very, very aware of the what we call the prodromal symptoms of an attack. The attack typically These prodromal symptoms start with mainly several days of insomnia, behavioral changes, feeling that your body is not normal. And then after that, with the ovulation, the attack starts, and it starts with, of course, the acute abdominal pain and the low back pain and all of that. So being knowledgeable of what are the prodromal symptoms of the attack is very, very important, since at that time you could share with your hepatologist or your whoever is treating your porphyria that you can get a dose of heme. We call it heme on demand to kind of like to abort that attack. I should be also mentioning that many of our patients try to eat more and increase their caloric intake around that time and gain weight with that. Okay, every month around that time they try to curb their caloric intake up. That practice, in our opinion, might have helped some patients, but it does not help the majority of patients. So this is something that we cannot recommend, but we would recommend the early recognition of the symptoms. And I can tell you that one of the symptoms that we all hear from multiple patients is the insomnia for several nights right before the attack.
Absolutely. So what I'm hearing you is definitely the moment that you start to pay attention of specific patterns that your body goes into prior to going into that flare, try to get that heme in as soon as possible so that you can abort that flare because once you're in that flare, the damages are greater.
That's exactly, and we call that brand of treatment or that category of treatment heme on demand. And ask your hepatologist always to put an order for a dose to be ready for you to go to the hospital and get it in the infusion center to just abort the attack.
Absolutely. Perfect. Wonderful. Thank you. Is neuropathy curable?
Well, the answer for that question depends on what the extent of the neuropathy. If the neuropathy has been there for a long time, we have to remember that this is unfortunately what we call an axonal neuropathy, meaning that it is hitting the core of the nerve. So if the nerves get exposed to for a long time to the effect of the delta amino alpha levulinic acid, basically the insult to the nerve is sometimes not repairable. And because the nerve, if it gets killed, if you kill the core of the nerve as an axonal neuropathy, the nerve has to grow back And that's a very, very slow process. And by that time that the nerve grows back, that pain will be more chronic, and there will be independent mechanisms for the pain to be chronic before the nerve grows back. So the answer to that is that prevention is typically way better than treatment if you are looking for cure. It can be under control, but curable, I would be honest, it is not a very realistic expectation once it happens.
Unfortunately, not the answer that all of us wanted to hear with AHP in this meeting, but you heard it. Prevention that we can certainly help. Now, this is an individual that clearly exercises a lot. They're capable of exercising, but somewhere in the midst of the exercise, they do feel that neuropathy pain, and the question is it bad to push through that pain?
I would say whenever you are exercising, and I would equate in that whether you're exercising with weights or or other form of exercise. In between the attacks, we think that what is happening is what we call small fiber neuropathy more predominantly, which is quite painful. If you personally can push through the pain and continue running or continue to lift weights and all of that, that's individual difference between a human being and another. But what I would ask is that if you are lifting weights and you having muscle cramps, stop lifting the weight on that muscle and change it to another muscle, because that's really when you know that you're damaging your muscles. So I would consider muscle cramps, and I say that to every patient, whether with neuropathy, whether porphyric neuropathy or not. If you are exercising, and we encourage you to do so, if you start to develop muscle cramps, if you are lifting with your biceps or something like that, try to switch to the other side, try to exercise another muscle, but cramps are really your limitations.
Okay, wonderful. Now, this is an individual that is 51 years old and has tried many things, including opioids. And the question is, can there be any other form of medication that can be taken outside of the opioids?
Well,
They have severe pain.
medication wise, what I typically try with patients who are on opioids is that I try to use the safe neuropathic medication that we know that are safe in porphyria, namely gabapentin, Lyrica, and Cymbalta. These are the three ones that I typically try first. Topamax is not safe in porphyria. I try to avoid that. Muscle relaxants are typically safe in porphyria, except one, which is the Flexeril or the cyclobenzaprine. That's probably unsafe. So I try to use a neuropathic pain medication and or a muscle relaxant that is safe in porphyria. Now, what if that all has been tried? Okay. I would honestly suggest a pain clinic that has a more of comprehensive pain rehabilitation response or pain rehabilitation approach, more than just going to the pain clinic, being looked down at, and they tell you to count your pills and all of that. Not just a pain clinic that they give you the pain medication. There needs to be some behavioral approaches toward these clinics. I think we call our pain clinic at Mayo Clinic PRC, the Pain Rehabilitation Center, because it has like a psychological management also. It does not focus just on medications or anything else. So I would say, I will reiterate, start the safe neuropathic pain medications and or the muscle relaxants if there are muscle cramps or muscle pain, and these should help. The most important thing is to avoid the medications that would put a patient into a porphyric attack, namely cyclobenzaprine is not that safe, Topamax is not that safe.
Wonderful. Thank you very much. What testing should be done to evaluate neuropathy due to porphyria, and how can you tell if the damage is from porphyria or something else?
That's a great question. So we have plenty of tools in our clinic that are under the disposal of any neurologist now. And we have first of all, we need to do EMG and nerve conduction testing that helps us to find out if you have what is called large fiber neuropathy. And this is the type of neuropathy that would involve the movement and the balance. And if that's normal, then we switch to testing the small fiber neuropathy. And small fiber neuropathy gained attention in the recent few years in between the attacks. And we have for that either autonomic testing or a test called skin punch biopsy, where we take a small sample from the skin, like an eighth of an inch, and we look at the small nerve fibers under the microscope and try to count them. And we have normative data for that site. And if you have less small nerve fibers than lower than the normative data, then this is what is called small fiber neuropathy. So we have actually three types of testing now that we do. Now, how to make sure that this is from porphyria? That's typically that's mainly by the history. We know that how the porphyric attacks sound, and they leave you with a residue of pain. The more attacks you, the more that you are in pain in between the attacks. But also, more importantly, we do everything on earth lab-wise to rule out other potential causes of neuropathy, namely diabetes, HIV, hepatitis C, many other tests. Like I typically order like 14 or 15 other tests to rule out any other etiology other than porphyria for the neuropathy.
What treatments for dysautonomia and small fiber neuropathy have you seen be successful to reduce pain, tachycardia, and POTS-like symptoms?
I have so what we know that now that between the attacks there is a problem in the vagus nerve, and the vagus nerve in porphyria, the vagus nerve typically acts to slow down our heart, put a check on the heart rate. So it slows down the heart when the heart rate does not need to be increased. Anytime in between the attacks, what patients have what we call cardiac vagus neuropathy. And when the vagus nerves start to be damaged, people start to have symptoms of resting tachycardia. And then that tachycardia could even get worse if the patient stands, given POTS-like symptoms. I would say that one of the most helpful medications for me, although it has mild effect on other patients, has been pyridostigmine, because pyridostigmine improves the acetylcholine, the neurotransmitter that the vagus nerve uses. So it improves the ability of the vagus nerve to function. Okay. And we've had some good experience with that medication in particular with some patients, including Myra, in kind of like curbing the heart rate a little bit and improving the dysautonomia symptoms. There are other medications, of course, depending on what sort of autonomic manifestations that the patient has. We tend to address those. We tend to address the low blood pressure. We tend to address the higher heart rate. But I would say most people have the resting tachycardia and the POTS-like symptoms. And for that, pyridostigmine is my first to go medication.
Perfect. You touched on something that we actually have a question on, and this was, first of all, they gave you props for the last webinar. They said it was fantastic. And then they said you talked about the vagus nerve damage from a porphyria attack causing severe chronic fatigue. Can this ever be resolved?
Again, this neuropathy is chronic and unfortunately axonal. It basically involves the core of the nerve. And with the small nerve fibers, those small nerve fibers are all cores. They are just like next to each other. They are the electrical copper part of the wire, and they don't have insulation. So when they are damaged in bulk. So once again, the cure, like the ultimate resolution, can unfortunately be an unrealistic goal. However, the symptoms, we can do our best to put them under control. And that's what we are talking about when it comes to the symptomatic treatment that we just talked about now.
Okay, excellent. After receiving my VP diagnosis, I also was diagnosed with central sensitization from years of porphyric attacks. What insight do you have other than drug intervention to help bring down the intensity of pain from central sensitization?
Yes, we talked about central sensitization, I think, and in the first part of this webinar. And we talked about the fact that it is one of the most important mechanisms of transforming the acute pain into chronic pain that will continue to linger throughout years. I would say that treating central sensitization with just medications is not a comprehensive, well-rounded strategy. Again, that's a situation when a referral to a pain rehabilitation center can be very, very appropriate. And this is the best that the patient can do, or the referring physician can do for them, I must say.
Perfect. Okay. No, this is very specific. I'm not sure if you're able to give a specific answer to this, but can you name a cannabinoid doctor who can recommend what mix to use for severe chronic pain from peripheral neuropathy caused by major porphyria attacks? Note, first and second line neuropathy drugs have failed to resolve symptoms.
I I don't have a lot of experience with recommending uh, cannabinoid because most of my practice has been before I moved to Arizona. It was in Alabama, and Alabama did not pass that bill till very recently. So I'm afraid that I cannot make recommendations about um, a pain doctor that dispenses or uses medical marijuana. But obviously, in my opinion, that line of treatment need to be explored by patients. And I don't think that we know too much to the degree that we can prefer a certain specialist over the other. So like this is something that can be like explored by the patient, but I don't think that it is that we know that much for me to pick a line of treatment or a specialist over the other, to be honest.
Okay, thank you.
Thank you.
We have also a question from an HCP question. Patient, I mean, this person is, the patient is 10 years old. And the question is, what tests can be done to figure out neuropathy and small fiber damage issues if she's this young? She has developed antihydroids, or
Okay,
hydrosis.
anhydrosis. Yes,
Uh-huh.
so yes, so the test that can be done is what we call the QSAR testing. We don't have, unfortunately, the skin biopsy is not that helpful we don't have good numbers for below 20.
Okay.
But however, the QSAR test, and spelled QSART, that test, our normative values go down to 9-year-old. So the only problem with that test is that while the skin biopsy is like 89% sensitive, picking like 89% of cases of small fiber neuropathy, QSART lags below that. It's about 72, from 69% to 72%, but it's still the test that we have for young patients like this, since the
Okay.
normal values extend down to 9-year-old.
Fantastic. This is back to dysautonomia. This person has tried Florinef, electrolytes, and compression, still not having any relief, specifically for hypotension and POTS-like symptoms with dysautonomia. What else do you possibly recommend for her?
It really depends on the results of the autonomic testing, if the patient underwent any autonomic testing. Many times, as I said, we found an injury to the vagus nerve and then pyridostigmine, or I saw a question about a patient who wanted me to repeat the name of the medication, pyridostigmine, or the brand name is Mestinon, Mestinon. That's if we find an injury to the vagus nerve. If we find an injury to the sympathetic nerve, which opposes the vagus nerve on the other side, and sometimes patients with porphyria could present with that if they are just recovering from an attack. In addition to the fludrocortisone, we can use a medication called midodrine. And midodrine and fludrocortisone are synergistically working together to raise the blood pressure sometimes. Basically, that's a medication that helps narrow the blood vessels in the leg. So that's how it raises the blood pressure and fight down the low blood pressure that some dysautonomic patients have. So there are options, but also they depend on whether you underwent autonomic testing or not, because autonomic testing is very, very helpful when it comes to choosing what medication we are going to put the patient on.
Okay. And this is a little bit probably outside of what we've been discussing, but this patient specifically is dealing with insomnia to the point where it is causing a lot of discomfort. They have been without a flare in the last 3 years and almost no pain, but the insomnia is extremely uncomfortable. Is there anything that you could recommend for them to do with that insomnia?
I wonder, like, what have they tried before and whether this is like safe in porphyria or not. The medications for nerve pain are always on top of my head, but the medications for insomnia are not. But are not that on top of my head. I mean, we always recommend checking on the porphyriadrugs.com whether the medication is safe in insomnia and porphyria or not. I would say that the problem with insomnia and porphyria, like the problem of insomnia in general, I would worry primarily if the insomnia is cyclical, meaning that it is preceding the day of ovulation in the patient for the like 3 or 4 or 5 nights, because that would be an alarming sign to me that the patient could be having like mild attacks without being aware of it, and that's damaging to the nerves. That is the point that I would worry about. But the treatment for insomnia is the same. We can search together about what medications, if Ambien is safe, or I'm not quite sure if trazodone is safe, but I would say that clonopin is also safe, but that's have its addictive properties, and many physicians would not be comfortable prescribing it, especially if the patient is already on a narcotic.
Absolutely. Well, we are exactly at 2:30 p.m. Pacific, 5:30 p.m. Eastern. So our time with Dr. Cozumel has ended for now. We will have him again at another session. But before I do let you go, Dr. Cozumel, someone is asking if you see patients under the age of 18. I believe the answer is yes.
The answer, unfortunately, no, but we try to make an exception. The reason for that is that the institution that I work in does not have a pediatric practice. So
I see.
if the patient is coming for a specific problem, I can make an exception and see the patient. But if I need a referral to another specialist, like if the patient needs a gastroenterologist or an endocrinologist, and I have a lot of interaction with those specialists on the adult side. Unfortunately,
Okay.
the other specialists that are working with me, they don't take referrals for under 18. And the only way for me to get a consultation for a patient like this is to send them to Phoenix Children. And I don't have yet a lot of experience dealing with Phoenix Children. And I don't want the patient to kind of like go through all of this.
Exactly.
So,
And they
so
are suffering with pain. Neuropathy pain is their biggest issue. So even if they were to get a referral directly to you for that neuropathy pain, the answer is they
I,
would not be able to right
I,
now.
it needs to be flagged as a case of porphyria, and I can make and I can try to make an exception for that. But the expectation should be set that I'm not going to be able to make any referrals within the organization, within the hospital that I'm working in.
Okay. The individual who posted about that, if you could please reach out to us. We will be glad to work with you to assist in making sure that you are able to see Dr. Cozumel. Then we'll jump through the hoops to ensure that the pain, which sounds like it's the worst, is taken care of. In the meantime, if we have not touched a particular question of yours during this Q&A, or you have any other questions that you would like for us to address, please send us an email at info@porphyria.org. That is info@porphyria.org. Please send us the questions. We'll be making sure that the additional questions that were not answered do get addressed, and we'll be sending out an email with all of the rest of the questions answered by Dr. Cozumel. In the meantime, thank you very much for being part of our community. We have several connect ups and we have many things going on. Please get involved in our community. We would love to see you be part of all the different things that we have going on within our community here. So thank you for your time. And Dr. Cozumel, thank you very much for your time.
Thank you so much. Thank
Enjoy
you.
the rest of the weekend, everyone. Bye bye.